It's the 12th of August, 2022, and this is the Room Now podcast. Hi, I'm Dr. Jack Cush, executive editor of RoomNow.com. We've got a lot to discuss this week. A lot of topics, things like psoriasis, RA, fatigue, sleep, sural nerve biopsies, tofacitinib and the oral surveillance study, HSP, mycophenolate, patient preferences. What's the order? Do you really have an order? I usually try to lump them together into themes, and today I'm going with like the top 10. And I got like 10 or 15 that I'm going to talk about, but what do you think is tops on this list? All right, place your vote now. Tops on this list is, yes, you guessed it, the tofacitinib safety 1133 oral surveillance study, uveitis and SPA, a new and improved Taltz ixekizumab, sural nerve biopsies, really, you like that? And then lastly, don't take stomach drugs with mycophenolate. Isn't that a strange mix? But based on what you read and what you clicked on this week, that's at the top of the list. So let's begin with the study that just doesn't seem to keep giving more information. It actually keeps going on and on. It's like the ever-ready bunny. It's the 1133 oral surveillance study wherein Xeljanz is studied against TNF inhibitors, adalimumab and etanercept. As you know, 4,362 patients followed for nearly 4 years gave us the bad news that maybe JAK inhibitors were associated with a higher risk of MACE events, malignancies, and VTEs. Or could it be the converse, that the TNF inhibitors were actually better at preventing those events in a high-risk population than the JAK inhibitor? We've discussed that in the past. This new analysis looks at infections with this specific JAK inhibitor, tofacitinib, and what they showed was that really across the board, the hazard ratios were higher for all infections, serious infections, non-serious infections, infections affecting the elderly. They were all higher with the two doses of tofacitinib, 5 BID, 10 BID, with 10 milligrams being higher than 5, and those were certainly higher than the patients who took the TNF inhibitors. Again, everybody was pretty equal going in with disease activity. And these people had really severe disease. You remember the SDI was 40, and they all got better in the study. But the numbers are pretty clear as to what happened here. Serious infections occurred almost 10 to 11.5% in the tofa group versus 8 in the placebo group. Fatal infections were 0.4% to 0.9%, low dose, high dose, in tofa versus 0.3% with the comparator, which was, as you know, the adalimumab. Patients also had, again, if they were older, they were the ones who had more infections than compared to the younger, being 50 years old, older being greater than 65. So there is a safety concern with these drugs as well, but again, it's not surprising. You're looking at the worst possible patients with the most inflammatory disease, with a lot of comorbidities in play. There should be a high infection rate in these folks. And it was high for both drugs, but a little bit higher, significantly so, with tofacitinib. There was a nice study that looked at the what happened when you had uveitis. The number that we've always taught was that patients who have, again, acute anterior uveitis is not infectious. 20 to 40% of them are going to have a spondyloarthropathy. In this study of 189 newly diagnosed non-infectious anterior uveitis, they found that the prevalence of SPA was 56%. Whoa, wee-o, as I like to say. Of those who had SPA, 93% were axial SPA, 7% were peripheral SPA. Of the people who had SPA, 3/4 of them were newly diagnosed with the onset of their uveitis. So again, you should buddy up with the ophthalmologist and say, your uveitis patients, speed dial me, I'll see them. The uveitis patients, what predicted having a spondyloarthritis as an underlying disorder? Psoriasis, odds ratio of 12.5. B27 positivity, odds ratio 6.3. These are really high. High CRP, odds ratio 4.8. And being male, a double of the risk, odds ratio 2.1. I think that was a kind of cool report. So did you, based on what you read and what you clicked on. You all like the announcement that Taltz, or ixekizumab, has a new formulation. It's a new citrate-free formulation designed to reduce injection site pain and stinging. As you know, ixekizumab is approved for use in psoriasis, psoriatic arthritis, spondyloarthritis, axial spondyloarthritis, and non-radiographic axial spondyloarthritis. And you seem to think that that was just hunky-dory wonderful. You know, I must say, I have not had much of this complaint in my patients, and I use a fair amount of Taltz in my patients with spondylitis and psoriatic arthritis. But all of you have told me, oh yeah, we hear it all the time. Well, now that problem seems to be in the rear view mirror with this new citrate-free formulation. Now, it seemed like in the past I did a lot of sural nerve biopsies in search for a vasculitis diagnosis. Obviously, it's a test you do in patients who have neurologic symptoms. Doing that as a blind biopsy is not a smart thing to do. But in this particular study of 91 patients undergoing sural nerve biopsy, they showed that what was important here was the length of the biopsy. Now, they didn't say in the abstract, and what I read, as you know, the usual length of a sural nerve biopsy should be at least 3 centimeters, and ideally 5 centimeters. In their hands, 44% of patients had a positive biopsy showing vasculitis. They said a positive biopsy was associated with longer sample length, other organ symptoms, ANCA positivity. So not surprising. And yeah, you should be doing sural nerve biopsy as a diagnostic test in some patients. A study of diet and RA, I like this study because it compared 100 newly diagnosed RA to nearly 200 age-matched controls. They showed that fish and seafood consumption was associated with a lower risk of rheumatoid arthritis, about a 50% lower risk, in fact. But processed meats, you know, your bologna, hot dogs, and whatnot, increased the risk of RA almost threefold with an odds ratio of 3.45. No increased risk was seen with red meats or poultry products. So I know a lot of your patients seem to want to cut out red meats. They should be cutting out ham, cured meats, bologna, things like that. A retrospective study of Henoch-Schönlein purpura looked at those who had GI bleeds. Of the 99, about 1/3 had severe GI bleeds, and 2/3 it was said to be mild, and 1/3 was moderate to severe, is the way they categorized it. Overall, they said the risk of a severe GI bleed had certain associations. 1, a summer association. This is a disease that does have a seasonal association. 2, the presence of a facial rash. I would have not expected that. High D dimers, high neutrophil to lymphocyte ratios. High D dimers greater than 0.9. NLR, usually it's high when it's greater than 4. In this case, when the NLR was greater than 10.5, that was your indicator. I don't know if you look at neutrophil to lymphocyte ratios, it's a cheap and easy a measure of inflammation and risk of infection and inflammatory disease. I just put up a tweet because I ran across something I was reading about the use of antacids and mycophenolate. Surprised to see that the aluminum hydroxide antacids like Maalox, Mylanta, and things like that lowers your mycophenolate Cmax 33%, area under the curve 17% if you take the antacid with the mycophenolate. Oh, and by the way, the same is seen if you take a PPI with your mycophenolate, and that lowers the AUC by 33%. I was not aware of this, and we certainly use a lot of mycophenolate. You should probably counsel your patients about splitting those two medicines up to 2 different times of the day. Speaking of mycophenolate, patients we know with lupus are not very adherent to their medicines, especially hydroxychloroquine. I found a small study that I think we printed today of 38 kids, and this is age 12 to 25, who had childhood lupus, and they looked at their adherence rate. They measured it multiple ways. It was pretty abysmal. 65% of kids were non-adherent to their meds for lupus. Half of them said it was because of the side effects. 33% said they had problems remembering to take the medicine. 25% said they couldn't afford the medications. Those who were taking mycophenolate 33% had a mycophenolate level that was basically less than 1, meaning that that's the number who was non-adherent, 33%. So this is kind of bad. How are we going to tackle this issue of non-adherence to our medicines? Again, it's trust building, it's counseling patients, it's identifying, what their wants are early on. That's really, really important, and listening to them, because often your wants are different than their wants, and you got to respect their wants, and that goes into what we call shared decision making. Fatigue and psoriatic arthritis. Fatigue in a lot of our disorders is getting a lot of play these days. This particular study looked at, I think it was 300 patients with psoriatic arthritis, and found that fatigue was present in 78% of them. Oh boy. And it was a yes/no fatigue question, and then a fatigue severity scale of 0 to 10. Severity was associated with greater disease duration and disease activity, skin activity, swollen joints, and functional impairment. All those things were associated with more. So basically, the worse the patient, the worse their fatigue. And this is something we struggle with, because you might get control of their joints, but you may not control their fatigue, and that may not just be fibromyalgia. More importantly, when they looked at the doctors of these patients and looked at their charts, of all the patients who declared that they had fatigue, fatigue was only listed as a problem, actually only listed anywhere in the note, in 32% of the physicians who wrote those notes. Meaning that we're probably not tuned in enough, certainly not enough for the patient satisfaction. Another PSA study, I think this is interesting, looked at what drives them to make the drug choices that they make. 150 patients. Excuse me, I got a kennel cough going on. And I asked them, what's your most preferred, reason to go on a biologic or to make a change? We tend to think of swollen joints and painful joints. That's not what patients think of. Number one, oral versus parenteral, sub-Q and IV. They prefer oral. Number two, they want to avoid side effects of medicines. Number three, they want to get back to normal activity. 4, they want to avoid infections. We in television have coached them up on that problem. Interestingly, they want to improve their psoriasis and their enthesitis they ask about. Remission is 7th on the list of priorities, and last on the list was joint pain. The point here is, again, what's important to them may not be important to you, and that might be a big mistake. Probably should begin or end every visit with what's important to you. What should we be paying attention to that we're not? I think you'd get a whole lot of conversation and respect from the patients if you did that. CARA, as you know, is a big registry of juvenile arthritis patients. They looked at patients of theirs who were on DMARDs or biologics and stopped them. It was a voluntary stop. Patients were doing well. But then the patients who flared and had to restart medicine, overall, what's the recapture rate on that? 55%, not bad. Highest in kids with systemic JIA, 69%, lower in patients with oligoarthritis. By 12 months, 2/3 of kids actually did achieve inactive disease with restarting medicine. They had a better odds of inactive disease, clinically inactive disease, when they initially were treated with biologics or when they restarted biologics. That was almost a 3-fold higher risk. I rag on the idea of drug withdrawal, drug tapering a lot. You've heard me, why would you do that? It's just nuts because there's a price to pay. But I must say that the recapture rates, especially if you're stopping the biologic, are good. The SEAM studies reported by Jeff Curtis a year or so ago looked really good in that regard. That was the RE-SEAM study. And there's a bunch of studies that basically say the recapture rate is really good. So it's not a horrible thing, but you may incur damage and may incur some difficulty. But this data is encouraging for those of you who like to do tapering or drug withdrawals. Cognitive dysfunction is linked to sleep. I think every rheumatologist knows that. A study of over 28,000 patients looked at those who had very low sleep durations, less than 4 hours, excessive sleep, greater than 10 hours, and showed a statistically significant decline in cognitive function when compared to those who had normal sleep hours. Yes, 7 hours or more is a normal amount of sleep. We don't talk about comorbidities much in other disciplines, but fatty liver is something that plagues our patients. Found an interesting report in the GI literature that basically said over 1 million patients, 17 countries studied. What's the prevalence of non-alcoholic fatty liver disease worldwide? Think of a number. You're not even close. My goodness, 32%? I found that surprising. I would have guessed like 15, maybe 20. It's 32%. It's higher in men than in women. And this number is higher than previous estimates. More importantly, the number is going up. In 2005, the prevalence went from 25% to 2016 to 38%. My goodness, the overall incidence of fatty liver is 47 cases per 1,000 patient years. It's something we have to deal with. CDC and MMWR came out last week on monkeypox, talking about the recent experience with, I can't remember how many patients, but it was a good number. It wasn't thousands. It was a few hundred. 99% were men, 94% had male-to-male sexual contact, meaning that they were gay or bisexual and whatnot. They underscored 100% of people have rash. But a lot of that, almost half of that, are genital rashes. So that may be something you're not seeing. You've seen the pictures of what monkeypox looks like. You know, these blebs, these bulli or papules on the skin that are shiny. And I think if you see those, you should be testing, regardless of what their background is or story. Something that looks like monkeypox should be tested. 2/3 have fever, 60% chills, 60% lymphadenopathy. They have a lot of rectal symptoms, bloody stools, purulent stools, rectal pain, rectal bleeding in 10 to 20% of patients. So something to look at. Increased mortality with giant cell arthritis. I don't like seeing these kind of numbers, but this was a Canadian study, appeared in Arthritis Care and Research. 22,000 patients from Ontario were assessed by diagnosis code and whatnot. They looked at the death rate in GCA patients over the age of 50. In 2000, it was 50 deaths per 1,000. In 2018, it was 58 deaths per 1,000. Moreover, the mortality rates have gone up. The standardized mortality ratio, 2002 was 1.22. In 2018, it's 1.92. We have new drugs we're not using very much in the way of IL-6 inhibitors in these patients. We're still clinging on to that drug that we seem to love, that's steroids, even in high doses. We might have to rethink and re-educate on giant cell arthritis management. My last report I found interesting. It was the association between CMV and ANCA association. This particular report said that if you had a prior infection with CMV, you are more likely to have venous thromboembolic events associated with your ANCA-associated vasculitis. As you know, CMV can cause vasculitis. Infections in CMV can cause ANCA positivity. We do know that ANCA-associated vasculitis patients have more VTEs. Now it's sort of trying to connect another dot between CMV and more VTE. So this was 259 patients. 12% of them developed, of the AAV patients, developed a VTE. And again, 60% of these occurred within the first 12 months of the diagnosis. The screening for CMV seropositivity did not have to be an acute infection. It could have been an old infection as well. But those kids, those patients, had a threefold higher rate of VTE, 16%, versus those that were seronegative, where it was 5%. That was highly significant. Ultimately, CMV seropositivity was an independent risk factor for future VTE in ANCA-associated vasculitis patients. Anyway, I hope you enjoyed this podcast. If you have any cases or questions, go to the email or the website. Look at the box that says Ask Kush Anything. Click on it. Record your question. We'll feature you here on the podcast next week. Love to hear from you. Take care.